Welcome to this explainer, where we're going to break down the dense pathology and high-yield genetics of colonic polyps. We'll make sure you understand exactly what to look for when diagnosing these vastly different growths. Whether you're gearing up for the USMLE or you just want a rock-solid grasp of GI pathology, this is exactly where you need to be. We're going to map out the critical genes, the distinct microscopic architectures, and those classic clinical manifestations that turn a simple little mucosal bump into a massive systemic clue.
Okay, let's dive right in by anchoring all this theory to a real-world scenario. Imagine an asymptomatic patient who is completely unaware of the ticking clock inside his gastrointestinal tract. It is so easy to get lost in endless lists of genetic mutations and histologic features, right? But remember, every single one of these pathologies ultimately presents as a real human being sitting in an exam room. So how do we synthesize their clinical picture with what we're actually seeing under the microscope?
Here is our agenda for today. 1. The case of Joe Wallace. 2. Non-neoplastic colonic polyps. 3. Neoplastic polyps and risk. 4. Hereditary polyposis syndromes. And finally, 5. Summary of colonic polyps. We have a beautifully structured journey ahead of us. We'll start with our clinical mystery, move through the harmless non-neoplastic polyps, tackle the dangerous neoplastic ones, and finish up with a deep dive into complex hereditary syndromes.
Section 1. The case of Joe Wallace. Let's get to our anchor case to give all this microscopic pathology some crucial clinical context.
Meet Joe Wallace. Joe is 52 years old, completely asymptomatic, and in seemingly perfect health. He denies any abdominal pain, any rectal bleeding, or any changes in his bowel habits at all. Plus, he has zero family history of cancer. Yet, a routine screening colonoscopy revealed a large, sessile, polypoid lesion with a velvety, hairy surface, and it measured a concerning 3 centimeters in diameter. It was immediately snare-excised and sent straight to pathology. I want you to keep Joe in the back of your mind as we go through this, because we're going to figure out exactly what his biopsy showed and what it means for his future.
But before we officially diagnose Joe, we need to establish that a polyp is, at its core, just a mucosal protrusion, and they range from completely harmless little growths to highly aggressive cancer precursors. Autopsy studies actually suggest that about 30 to 60% of adults have colonic polyps, and the vast majority are totally asymptomatic. Endoscopically, we describe them by their shape. If they're attached to the surface by a narrow, elongated stalk, they're called pedunculated. If they don't have a stalk and they attach directly, lying kind of flat or dome-shaped, they're sessile. But the real diagnostic power lies in figuring out whether they are non-neoplastic or neoplastic.
Section 2. Non-neoplastic colonic polyps. Let's look at how the body forms polyps that, thankfully, carry absolutely no malignant potential. You can clearly see dense inflammation in the lamina propria here, along with distortion of the glands and some surface erosion. These are just benign reactions to chronic cycles of injury and healing. Now, here is a massive high-yield concept, essentially blue text for your board exams, and that is solitary rectal ulcer syndrome, or SRUS. The pathogenesis here is pretty fascinating. It happens when the puborectalis muscle abnormally contracts when a patient strains during defecation. This essentially compresses the anterior rectal wall on the upper anal canal, leading to mechanical trauma, localized ischemic injury, and the formation of these inflammatory polyps. These patients, usually in their late 40s, will typically present with a frustrating sense of incomplete evacuation, rectal bleeding, and perineal pain.
Now, check out this classic tree-like smooth muscle proliferation, along with those circumoral dark macules. These are massive, undeniable diagnostic buzzwords for Peutz-Jeghers syndrome. This is a rare autosomal dominant condition, and for the USMLE, you absolutely must know the STK11 gene. This gene normally activates AMPK, which is a metabolic sensor. When STK11 undergoes a loss-of-function mutation, the PI3K/AKT signaling pathway gets activated, and that drives tumor growth. The result? These beautiful but highly abnormal hamartomatous polyps. They're composed of normal cellular elements, sure, but with a totally distorted architecture. Notice how the smooth muscle bundles dissect the lamina propria in this arborizing tree-like network. And whatever you do, don't forget the classic physical exam finding: pigmented blue-gray to brown macules right on the lips, buccal mucosa, and palms. While the polyps themselves are technically hamartomous, these patients carry a 40% lifetime risk of colorectal, breast, and pancreatic cancers.
Let's move on and build out our understanding of other hamartomatous conditions.
For your medical licensing exams, you really have to link juvenile polyposis syndrome, or JPS, to the SMAD4 or BMPR1A genes, which play a crucial role in the TGF-beta signaling pathway. These patients can develop up to 500 polyps and usually present before age 20 with rectal bleeding. The absolute buzzwords you need to lock in to separate it from other syndromes are pulmonary arteriovenous malformations and digital clubbing. Then we have Cowden syndrome. You must connect Cowden syndrome directly to the PTEN germline mutation. The classic clinical presentation includes these benign hair follicle tumors called trichomomas, macrocephaly, and a significantly increased risk of breast, thyroid, and endometrial malignancies. Master these specific gene to presentation pairings because they are incredibly highly tested.
Rounding out the non-neoplastic category, we have our hyperplastic polyps. Making up a whopping 85% of all colonic polyps in developed countries, these feature a really distinctive sawtoothed or serrated appearance. The core mechanism here is a failure of cellular apoptosis. Basically, decreased cell turnover leads to a piling up of goblet and absorptive cells. What you absolutely need to burn into your memory right now is that in a simple, benign hyperplastic polyp, this serration is restricted strictly to the upper third of the crypt. The crypt bases are totally, completely normal, and there is zero dysplasia. They have absolutely no malignant potential, but they are a crucial distractor for a much more sinister lesion that we're going to cover in just a moment.
Section 3. Neoplastic polyps and risk. So, the crucial point to take away is that while those hyperplastic polyps are harmless, this next category, the neoplastic polyps, is where the real danger lies. Because this is where dysplasia actually begins.
Here we're looking at the evolution of adenomatous polyps, which are benign intraepithelial neoplasms arising directly from dysplastic cells. The vast majority of these are driven by mutations in the APC gene, which you'll recall is a key negative regulator of the Wnt signaling pathway. On one side, we have a tubular adenoma. It's small, it's smooth, and it's packed with crowded, disorganized tubular glands. On the other side is a villus adenoma. Notice those slender, cauliflower-like surface projections that look remarkably like the villi of the small intestine. And as it turns out, this specific histology perfectly matches exactly what our patient, Joe Wallace, had. His 3-centimeter velvety mass was in fact a villus adenoma, showing intestinal-type low-grade dysplasia.
Now, you might be wondering, why is Joe's diagnosis so concerning? Well, keep in mind that only a small minority, about 5% of these adenomas, will actually progress to cancer over a slow, creeping 7 to 10-year window. However, that risk heavily increases based on two major highly tested factors: size and architecture. If the polyp is over 10 millimeters, or if it has a villus component like Joe's rather than just a simple tubular one, the malignant potential absolutely skyrockets. This is exactly why Joe requires incredibly careful surveillance and a mandatory repeat colonoscopy in 3 years.
Okay, this distinction right here is massive for medical exams. You must be able to confidently differentiate the completely harmless hyperplastic polyp from the highly premalignant sessile serrated adenoma, or SSA. Endoscopically, they can look totally identical. But molecularly, nearly 80% of SSAs carry an activating mutation in the BRAF gene, which operates right inside the MAPK signaling pathway. BRAF mutations are very rare in standard adenomas, making this a totally unique pathway to cancer. SSAs are typically found hanging out in the right colon. Let's look closely at the microscopic differences so you can see exactly how pathologists tell them apart.
Understanding this specific architectural difference is paramount. Unlike the benign hyperplastic polyp, where that sawtoothing is only at the top, an SSA has serration that extends along the entire length of the crypt, all the way down. Furthermore, notice how the crypt bases at an SSA grow horizontally. They become dilated and branched, forming this incredibly distinct inverted T, an L, or a boot shape. This architectural distortion right at the base of the crypt is the ultimate histologic hallmark of a sessile serrated adenoma. I can't stress this enough. If you see boot-shaped crypts on a board question, you select SSA, and you select the BRAF mutation, period.
Section 4. Hereditary polyposis syndromes. Let's scale up from isolated polyps to systemic, genetically driven conditions that drastically alter a patient's entire gastrointestinal landscape. These actually account for about 5% of all colorectal carcinomas.
Just look at this. Notice how this colon is terrifyingly blanketed by hundreds, sometimes thousands of synchronous polyps. This is classic familial adenomatous polyposis, or FAP. It's an autosomal dominant syndrome resulting from a really devastating germline mutation in the APC tumor suppressor gene. Normally, APC promotes the apoptosis of colonic epithelial cells by regulating beta-catenin. But when both alleles of the APC gene are mutated, functional APC protein is completely lost, beta-catenin accumulates, and colonic crypt stem cells just clonally expand wildly out of control. Because the colon is literally carpeted with these premalignant adenomas, classic FAP carries an absolutely staggering 100% lifetime risk of progressing to colorectal adenocarcinoma if left untreated. Think about that. 100%. The average age of cancer diagnosis is just 39 years old. And because endoscopically removing hundreds of polyps is physically impossible, a prophylactic proctocolectomy is the absolute standard of care here.
Now, the APC mutation actually presents in a few varied forms depending on the exact location of the genetic defect. Attenuated FAP presents with fewer than 100 polyps and a much later onset. But examiners absolutely love to test your knowledge of the syndromic variants. Gardner syndrome is FAP, plus some prominent extraintestinal manifestations. Specifically, look for multiple benign osteomas of the skull and mandible, impacted supernumerary teeth, and incredibly dangerous desmoid tumors, which is a deep-seated fibromatosis that typically arises in the rectus abdominis muscle right after surgery. Then we have Turco syndrome characterized by colonic polyps plus primary malignant brain tumors. Specifically, Turco syndrome type 2, driven by the APC mutation, is heavily associated with medulloblastoma.
You also must be able to contrast APC defects with two other highly tested syndromes. First up is Lynch syndrome, also known as hereditary non-polyposis colon cancer. Unlike FAP, Lynch doesn't carpet the colon in polyps. Instead, it's caused by defects in DNA mismatch repair, or MMR genes, most commonly MLH1 and MSH2. When MMR enzymes fail, short repetitive DNA sequences called microsatellites expand or contract, causing microsatellite instability. This leads to a rapid accumulation of mutations, shortening that adenoma to carcinoma progression from 10 years down to just 35 months. These cancers heavily favor the right side of the colon, and these patients have incredibly high rates of endometrial and ovarian cancers. Finally, contrast both of those with MAP, or mute YTH-associated polyposis. Unlike the others which are dominant, MAP is autosomal recessive. The mute YTH gene is responsible for base excision repair. It fixes oxidative DNA damage, specifically 8-oxoguanine. Without it, you get GC to TA transversions. These patients typically present later in life with maybe 10 to 100 polyps, neatly bridging the gap between sporadic polyps and classic FAP.
Section 5. Summary of colonic polyps. Okay, we have covered some incredible ground today, from molecular pathways all the way to macroscopic pathology. Let's tie all these microscopic and genetic clues together into one crystal clear picture.
Here is your ultimate cheat sheet for the USMLE. Seriously, lock this in. Take a moment to map the STK11 gene directly to Poached Jaggers and its pigmented macules. Connect the APC gene to FAP, Gardner's osteomas, and Turcot's medulloblastomas. Link the MMR genes, MLH1 and MSH2, straight to Lynch syndrome and its massive endometrial cancer risk. By organizing these diseases by their mutated gene and their extra gastrointestinal manifestations, you can instantly recognize the syndrome in literally any clinical vignette they throw at you.
By mastering these microscopic clues and genetic markers, from the upper third serration of a totally benign hyperplastic polyp to the boot-shaped BRAF-mutated crypts of an SSA, all the way to the Wnt pathway failures of FAP, you're now fully equipped to solve the clinical mystery behind every single polyp you encounter. The next time you see an asymptomatic patient like Joe Wallace with a 3-centimeter villus adenoma, you won't just see a mass on a screen, you'll see the exact cellular mechanisms at play, and you'll know exactly how to intervene. So, as you review your pathology sides today, I want to leave you with this. Knowing the hidden genetic triggers we discussed, how will you decipher which colonic polyp is a harmless bystander and which is a ticking time bomb? Thank you so much for joining me for this explainer, and keep that curiosity alive.